Professor Rashiduddin Ahmed sir. He was founder of neurosurgery in Bangladesh. As you know, today our chief guest is Professor Kanokhanti Barua sir. He is the he is the Professor of Neurosurgery and Honorable Vice Chancellor, Bangabandhu Sheikh Mujib Medical University. He is my teacher and mentor. And the webinar is presented by Professor A.T.M. Musharraf Hussain sir, Chairman, Department of Neurosurgery, Bangabandhu Sheikh Mujib Medical University. Today, our keynote speaker, Professor Loligam and Shekhar, Professor and Vice Chairman, Department of Neurosurgery, University of Washington, Director, Cerebrovascular Surgery and Director of Skull Surgery, University of Washington. He is one of the author of famous neurosurgical book, Principle of Neurological Surgery and Cranial and Microsurgical Approach and Techniques. Or another speaker, Professor Ashish Suri, Professor Head Unit 2, Department of Neurosurgery, Neuroscience Center, All India Institute of Medical Science. He is the faculty in charge, Skull-based and Cerebrovascular Neurosurgery Fellowship Program, AIMS, New Delhi, India, from whom he is my teacher, from whom I have taken training at 2010 at AIMS. Our panelist is another renowned teacher, Professor P.K. Mishra, President World Federation of Skull-based Society, Head of the Department, Surgery, Consultant Neurosurgeon and Governor of Surgery, PT Hindu Hospital, Mumbai. Another panelist is Professor Akhlaq Hussain Khan. He is the Professor of Department of Neurosurgery, Bangabandhu Sheikh Mujib Medical University. He is the Vice President of Bangladesh Society of Neurosurgeons. I am Professor Dr. Haradun Debnath conducting the meeting as a moderator. Now I am requesting Professor Shekhar to take his lecture on surgery of Cavernous Sinus Meningioma. As Professor Shekhar has given time for us from his busy schedule, he will answer our question just after his lecture. So if anyone has any question, then ask immediately after his lecture or inbox me on the chat section. Sir, you can start your lecture now. Professor Shekhar sir, you can start your lecture now.
Can you see my screen?
Yes, sir. Yes, sir.
All right. We're starting a little late, so I'm going to try to truncate this lecture because I have to leave at 8 o'clock. So let me, okay. All right. Let me display settings. Great. Actually, let's go. All right. So I'm going to speak about our current approach to cavernous sinus tumors from Seattle, Washington. Good morning. So the space, which is called the cavernous sinus, is a predominantly a venous space. It's a plexus of veins, and I like to think of it as a truncated pyramid. There are a lot of structures which are on the wall or right in the or adjacent to the cavernous sinus, such as the optic nerve. And then you have in the lateral wall, you have the third and the fourth and the fifth cranial nerves. The structure that traverses the cavernous sinus is the intracavernous carotid artery and the abducens nerve, or the sixth nerve, as well as the sympathetic nerve. And the cavernous carotid has generally two branches. Main one that you see most of the time is the meningohypophyseal artery. It's in the posterior bend. And then you also have this artery, which is called the artery of the lateral cavernous sinus. It sometimes gives rise to branches that feed tumors or CC fistulas. And also occasionally this will give rise to or give origin to the ophthalmic artery. And just medial to the cavernous sinus, you have the pituitary gland. Now, instead of thinking about all of these triangles, which have thousands of them have been named, I think that is meaningless because in the pathological situation, the triangles do not exist or they are highly distorted. So I like to think of the cavernous sinus as consisting of surfaces. So you have a superior surface, the lateral surface, there's a medial surface, the posterior surface, which looks into the clivus, and the anterior surface, or the apex, which is really the most crowded area, looks onto the superior orbital fissure and the orbit. So all of the approaches are going through one surface or another. And as I said again, the anatomy is generally distorted. So these are some anatomical studies that show the different aspects of the anatomy. I know that you're all quite familiar with a lot of this information, but here you can see the brain removed in the cadaver, the optic nerve, carotid artery, third nerve. And the third nerve has the shortest course in the cavernous sinus and is bordered by the anterior clinoid process, which you'll see right here, the clinoid, which has been resected, and here's the third nerve. And the third nerve is just running lateral to it. And here's the clinoidal segment of the carotid artery. So what's tricky about the cavernous sinus? Of course, the location is deep. The venous bleeding can be frightening. The most important structures are the intracavernous carotid artery and the cranial nerves. Damage to the carotid can result in a stroke and or death. Injury to the cranial nerves can create permanent issues, double vision, ptosis, loss of vision, corneal ulcers, etc. Of course, just getting there can be problematic. If you're using a transcranial approach, you can have problems due to brain injuries. If you're going through an endoscopic transsphenoidal or transpterygoid approach, you can have CSF leaks and infection. There have been, of course, a number of approaches that have been devised to the cavernous sinus, pioneered initially by Professor Parkinson, Dr. Dolenz, a number of others. On the other hand, there's been some level of retrenchment due to the advent of endovascular management, as well as the gamma knife radiosurgery, because we don't want to cause major deficits. And certainly some of the benign tumors can be managed by radiosurgery. One of the major issues had been how to control the venous bleeding. In the past, we used to pack with gel foam or Surgicel, but now we have injection of fibrin glue or powdered gel foam, which is, these are the techniques which I innovated years ago, which really helps stop the bleeding very quickly, especially injection of fibrin glue. But you should be careful not to inject too much, because if you inject large amounts, it can reflux into the venous sinuses. The carotid artery management has been revolutionized by both dissection, but also bypass techniques. So when you have an artery which is severely involved, then we can use various techniques of bypass. Cranial nerves still are very important and problematic. In most of the cases, we end up preserving them, but if it's a single cranial nerve, such as the fourth or the sixth nerve, repair is possible. And then, of course, reconstruction is very important to prevent CSF leak. And other forms of management, such as radiosurgery, and then also follow up with eye muscle surgery, all of these have been important. Now, when so I think about radiosurgery, for small remnants, radiosurgery is effective in stopping the growth for a number of years, although the tumor in some patients can continue to grow, and also there's a possibility of more aggressive transformation. So in the modern day, our patients, they demand less invasive approaches and better results. This is the trend everywhere. So this is what we need to take into account. For a lot of the intracavernous aneurysms and CC fistulas, nowadays the preferred technique is endovascular. For neoplasms or tumors, we think about either complete removal or incomplete removal with radiosurgery. And also then if you think about surgery, we think about microsurgery versus endoscopic surgery. So how do we evaluate these people? We have to do a very careful exam. MRI scan is, of course, generally performed and is very important. A CT scan, which is non-enhanced with bone windows, is very essential. For larger tumors, we perform angiography, but we also like to have an idea of collateral flow testing. So we may do common carotid compression testing. That's what we do rather than doing balloon occlusion tests. If you're expecting a bypass, you have to put the patient either on aspirin or clopidogrel. And during surgery, this is very important. It's good to have a central venous line, and blood should be available. And if you're doing neuromonitoring, some people still monitor cranial nerves of the cavernous sinus. I don't do that anymore, but there's certainly a consideration. Are you going to get proximal control, either in the cervical or the petrous carotid? We typically do either an orbitotomy or an orbitozygomatic osteotomy, depending on the extent of the tumor. Clinoidectomy and optic nerve decompression. How do you resect the tumor? And then if you are expecting a possibility of carotid injury, then you should have temporary clips and bypass instruments. So this represents my current approach to cavernous sinus tumors. It's very important to know whether the tumor is soft or firm, because softer tumors are generally easier to remove completely. Firm or fibrous tumors are more difficult. And also you need to know about the collateral circulation and cranial nerve deficits beforehand. And questions are also, again, about primary versus recurrent tumor, and whether or not the patient has had previous radiotherapy. You can also think about tumors which are arising within the cavernous sinus, which may start out as small tumors, tumors that are outside the cavernous sinus and going inside, and then finally radiotherapy. So for smaller tumors, one might think about observation, radiosurgery, or attempted total resection of the tumor is soft. In some patients, cranial nerve decompression only may be recommended to improve cranial nerve symptoms, and then proceed with radiosurgery. Now, if you have other tumors, which are the cartilaginous tumors, such as chondrosarcoma or chordoma, or trigeminal schwannoma, both of these varieties of tumors, complete resection is possible in the majority of cases. Now, with malignant tumors such as squamous cell or adenoid cystic carcinoma, then tumor removal may be recommended for oncological purposes. And in such cases, internal carotid artery bypass will be needed so that we can provide the patient with alternative conduit. And then a skull base repair is very important in these patients after you remove the tumor. So this is a compendium of tumors operated until 2020 from over the last 15 years here at Harborview Medical Center. You see, of course, all sorts of tumors, predominant being meningiomas, pituitary adenomas, cavernous meningioma, chondrosarcoma, chordoma, schwannomas, and so forth. The major complications, we had 3 patients with major infections, all of which were resolved. 2 patients with temporal lobe or subarachnoid hemorrhage, 2 who had enophthalmos, which were immediately corrected. We had 2 patients with graft occlusion, both were revised without stroke. 2 ICU injuries, which proceeded to graft. 1 patient suffered a brain infarction, but improved due to graft revision, and no CSF leaks or deaths. And cranial nerve results, we are still looking at that carefully. So my recommendations making today are evidence level 3. That means that no randomized trials have been done. So in your own experience and center, it's better for you to match your own experience and results to the care of the patient and to the patient's expectations. So I'm going to show you a few cases. I'm going to skip the videos because we started late. So here's a patient with a recurrent cavernous hemangioma, 77 years old, had a prior attempted resection and severe proptosis and eye pain, headaches. She was on steroids for 4 years continuously. On exam, she has poor vision in the right eye, subtotal third nerve paralysis, and starting to get visual involvement in the other side. So here you see a large tumor, very vascular, and this by angiography, the carotid artery is compressed forward, and you have blood supply coming from branches of the intracavernous carotid artery. The patient, however, also has very poor collaterals from the other side. So one has to, in a case like this, prepare for possible bypass. However, in a case like this, definitely most of the time, the tumor can be dissected from the artery, so forth. So here's the, again, what the before and after illustrations. So this patient postoperatively improved cranial nerve function of the third nerve. Vision was similar to pre-op. There's still a question of whether or not there could be some tumor remnant here, but it's very small, and she's just being followed. Just working through the superior approach, you could see complete resection of the tumor. His third nerve palsy resolved, and he was able to return to work, and he has no recurrence. Here's a patient with an extensive cavernous sinus and middle fossa tumor. And this is, here you could see tumors in the cavernous sinus, but also projecting into the middle fossa. So here, the main concern is to remove as much of the tumor as possible without damaging the patient. Preoperative studies, you can see the carotid artery is narrowed. We were able to do some embolization. The patient has a poor cross flow on angiography. And what we ended up doing with this patient was a near complete removal. However, we have left a little bit of tumor near the orbital apex and the anterior portion of the cavernous sinus. And the patient's cranial nerves reduced sensation in V2 and 3, right cranial nerve 6 paralysis, which improved on follow-up, and no other deficits. She was able to return to her work. And we are planning radiosurgery for the remnant if there is a growth of the tumor. Then this is the other side of the spectrum. This is a patient who's been previously treated by radiation therapy. This is a patient who was radiated actually in the UK. And the tumor, however, continued to grow. And the carotid artery was severely narrowed. And the patient has no vision in the left eye and has a complete ophthalmoplegia. And one can see that, again, it's a severely narrowed carotid artery, but no collateral circulation, none at all, no PCOM, no ACOM. So in a case like this, we need to be much more aggressive, and we need to resect the tumor completely. So how do we do that? We have to do some kind of a bypass. So in a case like this, because there were absolutely no collaterals, I did a double bypass, but it's probably overkill. I think a single one, a good one would have been enough. So there is actually a radial artery graft from the external and a saphenous vein from the internal after the first one is completed. And then we were able to resect the tumor completely. And once the tumor is resected, we have sphenoid sinus exposed. So we use a temporalis muscle flap to bring in there and then line this area so that there's no CSF leak, and this lady remains free of tumor recurrence. Now, this is the other kind of tumor that involves a cavernous sinus, a petroclival tumor invading into the sinus. So in this patient, was a very firm and difficult tumor. And then, the top half or top third is being removed, and that's a very critical part. And then we used a Petroclival approach to come at the posterior portion. This was a very firm. We were able to remove the portion against the brainstem, the posterior fossa. The remnant then was treated with radiotherapy. His main deficit is cranial nerve 1 paralysis. Lastly, I want to show you this case. This is a patient who presented with trigeminal neuralgia, severe atypical trigeminal neuralgia. And he was treated with radiosurgery. However, the facial pain became extremely severe and intolerable. And he presented with this tumor, which at this stage, you can see the carotid artery is narrowed, and tumor involves predominantly the cavernous sinus. Now, in addition to this, he also was having some ischemic symptoms. You can see that CT perfusion shows diminished flow, and you have some infarcts in the brain, chronic ischemic changes. And the cavernous, the angiogram, the cavernous carotid is severely narrowed. So what we did here was we actually did a bypass, and so this man had, you could see that we've only removed the outer aspect of the tumor, but we completely decompressed the cranial nerve. So this patient had a good outcome, much improved facial pain, etc. So I'm going to actually stop here because of the time limitation. We started late, and I'm happy to answer any questions for 5 minutes. So.
Thank you, sir, for your brilliant presentation. We have learned a lot of things from your lecture about the surgery of Cavernous meningioma. It will be helpful for us and also our young neurosurgeon to do this surgery. Now, as Professor Shekhar has lack of time, he will leave after meeting, after answering the question. Dear audience, please ask question to Professor Shekhar and write question on the chat box. Dear audience, please ask question to the Professor Shekhar. Now, I would like to request Professor B.K. Mishra to discuss about the Professor Shekhar's lecture. Probably he is busy with the emergency surgery. Now, I would like to request Professor Musharraf Hussain sir to comment on the Professor Shekhar's lecture. I am requesting Professor Konakanti Burua sir, our Honorable Vice Chancellor, to discuss on the Professor Shekhar's lecture.
Yeah, can I just make a comment? Hello?
Yes, sir, yes. Yes, sir. I'm hearing you. Professor Mishra, sir.
Yeah.
Comment on Professor Shekhar's lecture.
Yeah, it's a very nice. We have learned a lot from him. I have learned a lot from him. In fact, I learned my bypass from him. I spent some time. He had kindly invited me to his department in 1993 when he was in Washington. And during my stay, I saw 2 high-flow bypasses, and that's how the high-flow bypass in India started. We did the first one after I came back from his unit. So it was very nice overview. Second, I just have one comment about the cavernous sinus cavernomas. The small cavernomas, the cavernous hemangioma of the cavernous sinus, very nicely you demonstrated. There's a very bloody tumor. The small volume tumor, they disappear. They respond very well to radiosurgery. What is your experience? Do you have any comments on that?
I agree. Cavernous hemangiomas, especially when they're small, definitely they respond well to radiosurgery, and I think we can do that. Yeah, right.
Yeah, thank you. I think the other people, let the audience ask. I have seen him many times, so let the other people ask him.
One more thing, yeah, I want to mention that Dr. Mishra and I have had a long association. I also did a few cases with him in Hinduja Hospital in Mumbai, in fact, including radial artery graft bypass in a patient
that incidentally was in part of the conference workshop. Actually, the radial artery bypass graft was part of a conference workshop which you did. Yeah, it's a giant.
See,
giant.
It was a relative. Yeah, the giant aneurysm was a relative of a cardiologist from Cleveland Clinic, if you remember. Yeah. So yes, and of course, Dr. Mishra is one of the leading neurosurgeons of the world, and I really appreciate being on the panel with all of you here. And I have to leave very soon, so I thank you.
One question from the honest share. Can we understand the indication for radio surgery versus open surgical removal? One question from the audience. Can we understand the indication for radio surgery versus open surgical removal?
I can't understand your question. There's a lot of echo there in the back.
Now I'm requesting Professor Konkanti Gurulasa to discuss about the Professor Shekhar's topic. Honorable Vice Chancellor, Bangabandhu Sheikh Mujib Medical University.
Thank you, Professor Shekhar, for your wonderful lecture. For cavernous sinus surgery, we know that hemorrhage, CSF leakage, and neurological deficits are the problem. In your experience, in your vast experience, what problems you have faced?
I believe I showed you one slide which outlined all the complications in our series. I don't know if you saw that slide. Maybe it went by very quickly. I have in that slide detailed the issues, some of the complications in about, I think now around 150 cases in the last 15 years. I mean, I've been doing this for a long time. I would say it's an evolved approach. Now we are more conservative, I would say in general, by and large, with vascular lesions. Unless it's a paraclinoid, we rarely operate. And of course, there are cases, giant intercavernous aneurysms that are extending, or endovascular treatment is not possible, then we are doing bypass procedures. For tumors, the problems are related generally to severe cases, because we also get cases where previous approaches have failed, where bypasses are necessary, or malignant tumors where the patients have some problems. So thank you for your question.
Thank you.
Okay.
Thank you, sir.
All right. Thank you very much.
Can I ask a question, Dr. Shekhar? Yeah.
Yes, sir.
It's been very nice to see you again, sir.
Nice to see you.
So, question is something regarding the cavernous meningiomas. I've seen that when you're taking out these meningiomas, someone muted me. Yeah, there is a subset which is exophytic, going into the intradural, as well as it goes into the cavernous sinus, and also in the Michel's cave, which can be resected. There's another subset which you are discussing about, which is truly intracavernous, and it has an exophytic component, but it invades into the adventitia of the carotid and also its branches in infloreal trunk. Is there any possibility of predicting such tumors preoperatively?
No. The only thing I would say is that MRI scan, I mentioned this earlier, is the tumor soft or not? What determines how well you can remove the tumor. Sometimes when you see low density on T2 weighted imaging of MRI, you can predict, but many cases it's not possible to say unless you actually get there. Sometimes you think it's going to be a very difficult case, and then you get in, and then you end up removing the tumor. So I think the indications are very important, and also expectation that you're not able to be radical in every case. That's something that the most important thing is to preserve the patient's function and provide long-term control, But you also have to take into account that some of the patients may not come back to you. Same situation in Bangladesh or in India or even in the US, and they're from a distance, whatever treatment you give is the one treatment, and then they may disappear, or they may have trouble getting back to you. So those are all things that also you need to think about.
I think it'll be very important, especially with the new classification of meningiomas coming in. Probably, I think WHO will announce it in 2021 with methylation and a lot of markers. I think all these, they would have a lot of bearing, especially with the radiology later, maybe.
Very good. Yeah. Thank you so much. And I thank you all for your attention. I have to leave shortly. Yes. Okay.
Thank you
Bye-bye.
very much.
Thanks again.
Thank you.
Thank you, sir.
It's very good to see all of you. Bye-bye.
Thank you.
Thank you, sir, for your resourceful lecture and giving us your valuable time. It will be guide for our young neurosurgeon and also for us in future surgery of Cavernous sinus meningioma. Now our second speaker, Professor Ashish Suri, takes lecture on surgery of Petroclival meningioma. Please, sir, start your lecture now.
How much time do I have, Harlan?
45 minutes.
Okay, good. So I'll just share my screen. Is my screen visible, Harlan?
Yes, sir. Yes.
Yes, sir.
Okay.
Visible,
Just
sir.
let me know if my audio visual is interrupted so that I can get back. So thank you for the kind invitation. It's always been a pleasure. And thank you, Professor Shekhar and Professor Mishra and Dr. Khan, Dr. Nath, and always Dr. Barua has been an inspiration always. So this is my personal series, 54 cases, last 16 years after I trained with Dollins and then Kawase. And most of the cases were very huge. They were more than 6 centimeters in size. And some disturbance. Shall I stop?
Sir, it can continue.
Okay. So there were a lot of. Thank you. Well, the clinical presentation, I think this is data that we are going to publish. I think Ravi is on the job. So I think 6 centimeters, 6 of our tumors. Six of them were more than 6 centimeters in size, and brainstem compression in more than 80% of cases. T2 hyperintensity in the brainstem more than 50%, and arachnoid plane was seen in 52% in patches. And these are important because the cavernous sinus extension was there in 70%. Despite that, so we did we had nearly 45 out of these 54 had MDK approach, and in 7 we did a conjoint retrosigmoid. It was a combined approach. So I did only one which was pure MDK, and one with the complete approach. So gross total excision in 43%, and near total, just leaving us a bit of tumor on the cavernous sinus where it was inoperable. So around about 75, 67%, I think, was near total plus gross total. Subtotal in 33. I'll skip this. There was some improvement in nerves, and there was some deficits. And I think the nerve which had the most new deficit was the 6th nerve. So that was the one which is there. You can also there was part of. This is most important. We analyzed our results and we found that the poor predictors were brainstem compression. It was not the size actually. It was not the predictor. The size did not matter too much. It was the brainstem compression, the brainstem edema, that's the T2 hyperintensity, and the arachnoid plane. On multivariate analysis, the T2 hyperintensity and arachnoid plane presence was the most important. 66% of our patients improved, and 29% were the same, and 5 deteriorated. So these are the literature, so it was compatible world over series. The gross relaxation rate was 40, 60, and 30. So ours was 43%. Gross total and near total was 24. So this was a meta-analysis. This is a recent paper in which they said that gross total excision is around about 68%, and complete resection, they said. So complete resection is difficult to say, especially when there's cavernous sinus extension. And then they compared the petrocil versus the retrosigmoid group, and they found that the petrocil group has most fourth nerve injury, and the retrosigmoid has post-operative seventh nerve. I think Haradan has been there in 2010. It was a small lab now. Now it's an international facility. I personally feel that surgical training is a must for all neurosurgeons, and hands-on training. It cannot be done on patients. It's becoming difficult on cadavers, and cadavers cannot give you.
We have learned a lot from your presentation. This will be helpful for us and also our future generation. Petroclival meningeal surgery. Now floor is open for the question and answer session. Thank you, dear participant, for friendly and unique participation. This time, I am inviting Professor Mishra to say something as a panelist. Professor Mishra probably engaged in the emergency operation theatre. Now, I am appealing Professor Akhlaq Hussain Khan to tell something about today's topic. Professor Akhlaq Hussain Khan. Professor Akhlaq Hussain Khan.
Hello, Haradun, can you hear me?
I'm requesting to tell something about today's topic as a panelist.
Hello, Haradun, can you hear me? Hello.
Yes.
Oh, thank you. Thank you very much, Professor Ashish Suri, for your excellent deliberation. And the first speaker, Professor Lelingham Shekhar, also our Cavernous Sinus, and Professor Ashish Suri, Petroclival Meningioma, which is elaborately and selectively classified and presented. Definitely we are benefited from your brilliant lecture and enjoyed your challenging surgery. On behalf of the Department of Neurosurgery, Bangabandhu Sheikh Mujib Medical University, we are grateful to you and keynote speaker, Professor Ashish Suri and Professor Lelingham Shekhar, and our beloved teacher, Professor B.K. Mishra, as a panelist. And we hope we have learned a lot from you, and we can apply your skill, approach, and knowledge in our day-to-day practice. And I personally follow the book written by Professor Lelingham Shekhar, the cranial microsurgery and approaches and technique, which I personally always follow this book. And thank you, sir. And also thanks to the learned participants and speaker of this webinar. Especially I'm grateful for inspiration, Professor Konokanti Borua, our Honorable Vice Chancellor, who is always inspiring us in the field of neurosurgery, field of modern neurosurgery. And I'll always give special thanks to Professor Musharraf Hussain, who is the chairman of the neurosurgery department. Thank you all.
Other than any questions from any delegates?
Yes, sir. There is a question from Professor Akhlaq Hussain Khan.
Can I ask one question, sir?
Yes,
hi, how are you, Diman?
Hi, sir. Hi, sir. Good evening, sir. So, as usual, your magical hand. We enjoyed your magical surgical skills.
We've been friends. No magic.
I still remember when I was with you. So, when you're adopting the retrosigmoid approach, do you recommend to do it in sitting or in power by exposition?
Well, all my vestibular schwannomas, I do retrosigmoid, all of them. You've seen me many other times, and I still continue with that. And all of them are in lateral position, lateral park bench. But when I'm doing them petroclival, it's only a combined. When I do them, I combine a retrosigmoid when I talk, especially when it's going lateral to the internal aortic canal. and so it's like a supine oblique then. So that's the only time I do retrosigmoid combined with a temporal, extended temporal.
So supine oblique means? Sorry, sir.
Supine oblique, because you have to do a temporal craniotomy. So you're putting the head like this, and the incision goes like this. So you open the temporal and you open the retrosigmoid. That is the only time when I do a combined approach, when I do it supine oblique. Otherwise, all retrosigmoids are lateral.
No, I am asking for whether you recommend for sitting position, semi-sitting position.
I actually do not. I like sitting position, but only for posterior third ventricular tumors, not for anything else. I know Dr. Swami and Dr. Goel are. I think lateral position is pretty good. The best thing is you can actually sit down and do it. Sitting position is tiring. It is tiring for the surgeon as well, and it's riskier for the patient.
So, yeah, Dr. Haradan, can allow me another question?
Of course.
Yeah, when we challenging that is big petroclival meningioma crossing the midline, any tips for that? How to combat the retraction?
Most of the petroclival meningiomas would be crossing the midline, because the main idea is what they do is they have to cross the midline. It is usually very rare to cross the opposite side petroclival and the petroclival suture. So it's usually the situation, if you see, it will be usually an ipsilateral. It will go till the one suture, till the inferior petrosal sinus, but not to the other side. So that's the problem with retrosigmoid approach. It is blind towards the basilar artery and the opposite perforators. But if you're taking the extended approach, it's much straighter. You have a better control there on the basilar and the perforators. You're mute. Diman, you're mute.
So, do you recommend to leave some tumors when I cannot reach and there is more retraction?
No, actually, the retraction is not a problem. If you saw my surgeries, there was hardly any retraction because the brain is actually falling down. So there's practically no. So retraction is never a problem. The problem is that the tumor is adhering to the vessels and the nerves, and you must take your time and dissect. But if you cannot, I think it'll be better to leave the tumor. We have done subtotal resection in probably more than 24% of cases. And I think 33% of cases. So I think that you have to do that.
Thank you, sir. Thank you, sir.
Thank you, Professor Diman Chaudhary, for your unique question. Now, I'm one question to Professor Ashishri sir. If there is any helpful endoscopic assisted tumor resection in case of petroclival tumor resection?
Petroclival meningiomas require actually I do a lot of endoscopy, and my endoscopy is I love endoscopy for ventricular cases, for all the hydrocephalus as well as for cysts as well, and all my pituitaries and craniopharyngiomas now are endoscopy. But I feel that microscope still wins over endoscopy, especially when you have to dissect. But and it is even for small diaphragma cellular meningiomas. Now it is proven that you can probably do a better job transcranial rather than endonasal. So the problem in endoscopy is that you cannot dissect bimanually, and you don't have a 3D vision. Even if you have a 3D scope, it'll be a virtual 3D. It'll not be a real 3D. But the real 3D is always from a binocular of the microscope.
Question from the audience in the chat box. What's your opinion about retrosigmoid suprametal transpectrosal approach?
Well, that's a good approach, and some people use it. I think even Dr. Shekhar uses it, and they're very comfortable with that. I love a retrosigmoid approach, but I use the suprametal only for sometimes for an epidermoid, in which I have to drill that area to reach the Meckel's cave. But most of these tumors, the petroclival meningiomas, they extend much more into the cavernous sinus, and sometimes they have You go above the tentorium into the temporal and dig into the temporal lobe. So this is not the right approach for those cases. When you see, Petroclival has a big spectrum. It's not only Petroclival, it goes over so ultimately the name can be Petroclival tentorium. So that can be the actual name of this tumor.
Sir, I'm now requesting Professor Jilur Rahman to say something about Professor Ashishuri's topic, surgery of Petroclival meningioma. Professor Jilur Rahman. Professor Jilur Rahman. I'm requesting Professor Jilur Rahman. Sir, probably is not in our online. So I'm requesting Additional Professor Pankaj Singh, Additional Professor of Neurosurgery, All Indian Institute of Medical Science, to say something about today's topic. Probably he is not present. May I request Professor Oshit Chandra Sarkar from Dhaka Medical College, Head of the Department, Dhaka Medical College, Neurosurgery. So, thanks to the audience. Now, I would like to request our Honorable Vice Chancellor, Professor Khonkanti Borua sir, to share his experience regarding this topic. Professor Khonkanti Borua sir.
Thank you, Professor Haradun Debnath. First of all, I must congratulate Professor Ashish Shuri for his wonderful presentations.
Thank you, sir.
His dissection and the way he has taken out the tumor from this petroclival region is a very, very wonderful thing I have seen. It's a petroclival region it's a formidable challenge actually for neurosurgeons because of their locations deep within the skull base and proximity to eloquent neurovascular structures. To take out completely or total removal or gross total removal is very challenging, increasing the morbidity and mortality. Can it be a option to remove the tumor subtotally and treat the rest portion can be treated by radiosurgery? Can it be a portion? What is your opinion? And it's the modality of treatment. Can it be?
Yeah, I think even if you see my results and the subtotal, which I said more than 10% of the tumor has been left behind, was there in probably 34% of cases. So that means 1/3 of my cases still had 10% of the tumors left behind. But still, nearly 67% of cases, we try to remove them completely or maybe less than a very small part. The problem in petroclival meningiomas is when you are decompressing, even if you have a navigation and an image guidance and all, you cannot really predict that how left behind. And the problem, and these tumors are just like the clinoidal meningiomas. You cannot, they're probably worse than clinoidal meningiomas. The clinoidal meningiomas, the radiation will damage the optic nerve. Here, it'll damage the midbrain. So how much radiation can you give? And these tumors are most of the time invaginating and pressing over the brainstem and are very adherent to the perforators. So how the patient, yes, I've operated a couple of patients who've been given gamma knife outside, and practically I could not even take out 50% of these tumors. So operating them again after radiotherapy is a disaster. You cannot, now I don't touch them. If someone has given radiotherapy to them, I don't touch them.
Thank you, sir, for nice discussion.
Thank you very much. Thank you.
Thank you,
We
sir.
have learned a lot from your presentations. Thank you, Professor Shuri.
It was an honor coming. Thank you so much.
Thank you, sir, for nice discussion. At last, I am requesting Professor A.T.M. Musharraf Hossain, sir, Chairman, Department of Neurosurgery, Bangabandhu Sheikh Mujib Medical University, deliver his valuable speech as a president of this webinar. Professor Musharraf Hossain, sir. I am requesting Professor A.T.M. Musharraf Hossain, sir.
Professor Haradun, thank you. Can you hear me?
Yes, sir. Yes, sir.
Yes, sir. Yes. It's a wonderful session to listen to and giants delivering these two lectures. Our first speaker, Professor Laligam Shekhar, the cavernous sinus meningioma, and the last but not the least, the Professor Ashish Shuri, the Petroclival meningioma and the elaborated dissection and techniques. And actually, on behalf of Neurosurgery Department, BSMMU, I must thank and congratulate both the speakers that they have enlightened us, and particularly our junior colleagues, and also we all learn a lot from these two vivid lectures. And definitely the interactive session teaches us a lot. And one thing I must thank Professor Ashish Shuri, that he is organizing particularly the training program, and the need of a skill lab and the hands-on training is the best way to learn. And particularly the coming neurosurgeon, just he is his conclusion, he said that always there must be replaced someone. And I must agree that our generation will be coming up and learn a lot from these interactive sessions. And on behalf of our neurosurgery department, BSMMU, I again thanks them. And I must also acknowledge and thanks the Square Pharmaceutical and the RAS TV for act as a scientific and cooperating with us, particularly the neurosurgery department of BSMMU. I'd like to thank all of them. And again, thank you very much, everyone, and particularly for joining this interactive session up to the late night. Thank you very much. Thank you, everybody.
Thank you, sir. Thank you for the kind invitation.
Sure. Thank you, sir.
Thank you,
I
sir.
would-
Professor Shuri.
Thank you. Thank you, everyone.
Thank you.
Thank you, Shuri, Professor Shuri, again. Thank you.
And my last message to all the residents and young
Bangladesh.
people, that please learn anatomy and skills.
Definitely, sir.
Learn again and again and again and again.
Again and again.
I did that when I finished my residency, and I went to Dr. Olinko Dollins, and then I realized I should have done it during my residency. So learn and keep on learning. Your microscope and endoscope should become your eyes.
Thank
Special
you.
gratitude
Thank
to
you
our
again.
keynote
Thank you,
speaker.
everybody.
Thank you.
Special gratitude to our Vice Chancellor, Bangabandhu Sheikh Mujib Medical University. Thank you all the participants for your patient sharing. Special thanks to our scientific partner, Square Pharmaceuticals, and media partner, RAS TV. Now, with the permission of President, I would like to end the session of meeting. Stay safe, stay healthy. Thank you all.
Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.